Good evening and welcome to EASL Studio, your weekly hepatology broadcast news. My name is Aleksander Krag. I'm a hepatologist based in Odense in Denmark. In today's episode, Steatotic liver disease, Unpacked, targeting the dynamic risk, we aim to discuss how to personalize care in the intersection between cardiometabolic drivers and alcohol, and how we in the clinic manage and address cardiometabolic risk and the dynamic nature of alcohol. And try to understand that and put in a practical clinical context. I'm privileged and honored to have a brilliant faculty from United States, Meena Bansal from Mount Sinai, New York. Welcome, Meena. And from Linköping in Sweden, Mattias Ekstedt, and from VCU Richmond, Virginia, Arun Sanyal. So good afternoon, everybody, or good morning. So before we take this, I want to discuss, or have you just identify one thing you think is exciting. These days, we have tons of papers coming up, endless meetings. I don't know, lots of it is probably a little bit noise, but from your perspective, looking back maybe a few months, one thing you said, wow, this is interesting. This is going to change my life or my patient's life or my practice. I don't know, Mattias, what you want to give it a go? What have excited you? You had a smile there, I could see.
Yeah, sure. And I immediately break the rules and haven't the one specific things, but to me, it's the amount of data in alcohol, MET-ALD that has surfaced after the new nomenclature. And I think that has just blown my mind from quite small interest in alcohol markers. Now the data is just starting to explode. And to me, that is just astonishing and a great achievement of all of us.
Just between you and me, I fully agree. The biggest achievement of the new nomenclature was actually putting alcohol on the agenda and driving a lot of research. But let's move on, Meena. So from you, from New York, what does it look like there of exciting stuff coming?
Yeah, I mean, I definitely agree that with the comment that the nomenclature really highlighted the important role of alcohol in all of this and drawn a lot of attention. But for me, one of the most exciting things in the past few months is the work showing that cirrhosis regression in response to bariatric surgery was associated with improved outcomes, as well as now some early data that pharmacologic intervention can also result in cirrhosis regression. I think cirrhosis has been a bit of a tough nut to crack because of the kind of prolonged period, and you're very different in the early stages versus the late stages.
I guess that was the wonderful data presented at the great congress that was just held in Amsterdam at EASL Congress. I agree, that's really breakthrough, that reversal of fibrosis. So anything left for you, Arun, that is not already captured, that you always know everything. So is there anything?
Meena stole my thunder a little bit because I was also equally excited about the emerging data with FGF21 and improvement, actually regression of cirrhosis. You know, it's one thing to say you're reducing scar tissue. It's another thing to say you're actually pulling people back from cirrhosis. So I think that's incredibly exciting. But I would just to add one more layer to this, I would say our paper in the New England Journal from last week in demonstrating the benefit of semaglutide, particularly with respect to both steatohepatitis and the scarring of the liver, the fibrosis. I think that is going to have a huge immediate impact because this is a drug that's already available on the market. It is a drug that has established benefits for obesity, diabetes, cardiovascular outcomes, even maybe chronic kidney disease. And now we add the liver to this. So I think this will change the way we approach therapeutics. And therefore, I think this is one of the most impactful papers in the recent past.
And I guess if you add that it might decrease alcohol cravings as well, we're kind of getting multiple things kind of happening here.
Exactly.
Expectations are high there. Let me just leave the FGF21 as a cliffhanger as the last question when we look into the future. But for now, I think it could be interesting. Maybe I can go back to you, Meena, there, because the first drug, resmetirom, was approved, I guess, a bit more than a year ago. We don't have it in Europe yet, but we expect it will come soon. And we already have semaglutide is not approved on this indication. But what would be interesting to know is from your experience during the last year, how has these changed your clinical practice? Or did it change the practice? We've been screaming for this for decades, and now finally it's there. So how does it change your practice or your priorities or your clinics?
Well, I think that it has stimulated more screening in primary care and endocrinology to identify patients who might have significant fibrosis and then send them to us. So I think it's had a tremendous impact on the field, kind of the upstream field. For me personally, now it's nice to have something that I can offer patients who meet criteria, and it's kind of the gratification that you can start something and monitor them and see that fibrosis regression, reduction in liver enzymes. So I think it's been a huge thing, and I think it opened up the field as well. It in and of itself, having one approval has jump-started the field again, kind of like cardiac arrest.
How did it feel? So did it feel like it felt like a disruption is a revolution, or more like a whatever change or
Opening of the floodgates.
Yeah. Do you agree, Arun?
Yeah, I do actually, because the first drug to be approved opens the door and clarifies the roadmap that others have to follow. And our initial experience with this has been that it confirms what we saw in the clinical trials, that it is by and large very well tolerated. And the patients, all the NITs tend to improve. And overall, the patient satisfaction from resmetirom is very, very high. I was particularly pleased to also see the open label data presented at EASL just last month, where even in people with more advanced disease, there are these non-invasive profiles of people with clinically significant portal hypertension. And that a large number of these patients, almost 2/3 if memory serves correctly, actually improved and no longer met criteria for clinically significant portal hypertension based on non-invasive tests after treatment with resmetirom. Together, I think this makes a compelling profile, A, for resmetirom, but B, it opens up all these new possibilities of combining with other molecules as combination therapeutics for more difficult to treat subpopulations.
Okay, but let me ask you, Arun. So in VCU, during the last year after this, can you give some concrete examples? Because next I will ask Mattias, what's coming to us in Europe? So we're still waiting. But what should we prepare for? What did you do? What have you changed? So looking back, what should you have changed or probably done better, or that we can benefit from?
I think it was interesting, I'm just sharing our own personal perspective, that the initial uptake was relatively slow. Some of it was our own faculty. They were very hyper-focused on this 10% placebo-corrected improvement in fibrosis, which they thought was relatively modest. And I personally don't know how much of it was how the messaging was given to the patient, but we heard back a lot of patients were sort of a little reticent about getting on the drug, but that has changed over the last 6, and some of it was just probably the early experience of how do you talk about a new drug.
Isn't it often like that? We have a lot of resistance in our own lines, actually. We tend to be skeptical.
So sometimes the physician is the problem, And I think given the NIT, now that we've started treating more and more patients, and we're seeing such dramatic improvement in all the NITs, not just one, but a whole bunch of NITs, I think that there's much greater uptake even among the physician community here at VCU. And I think this is translating into a dramatic increase in the number of patients getting treated as well.
And Arun, which patient do you decide to treat? What's the workup and the most important criteria to start treating.
I'll come back to that question.
Oh, sorry.
First, I just want to let for you, Mattias, you're again a public healthcare system. I don't know, we're not Veterans Affairs, but something. But how do you imagine this will be implemented in Europe? Because very soon these will be approved, and we have a ton of patients also. How do we actually bring the best drugs into the patient, the right mouth at the right time with the most benefit? How do you see? What should we do?
Yeah, I mean, the Swedish healthcare system, we have a one-payer system, but it's but still, so everything needs to be reimbursed. But I will be able to prescribe anything I want. So that's a bit strange, because I can prescribe any drug, and as long as it's reimbursed, it's reimbursed. But I'm not fully convinced that resmetirom will be fully reimbursed in Sweden. I think they will put up some criteria, and I don't think the floodgates will open in Sweden, not to start with. And this is a different landscape in different countries in Europe. I think some countries, there the floodgates will open because reimbursement will be open for everyone. But in Sweden, I think it will take time to start using.
Who would you prioritize, Mattias? Who should you prioritize? What patients should we actually look out for now and prepare? And there's been a tendency pushing a lot of things because the healthcare system under pressure. Who should go back to primary care? Who should really make sure we don't lose them, and then they come back whatever in 5 years with a decompensated event or something like that?
Yes, I mean, in our clinic, I mean, FibroScan is used constantly. So I think the ones that have FibroScan, let's say above 10, should be kept and be prioritized when we start treating patients.
Okay, but then let's try to dig into the healthcare pathways, how you do, again, trying to learn from each other. And again, the different thresholds, different kinds of reimbursement. But Meena, when you do, how is the flow with you or the pathway from suspicion? So who do you see referred, and how do you then actually walk them through the steps through staging and indication for treatment?
So I would say patients come to me probably in 3 ways. One, a workup for abnormal liver enzymes, and you kind of rule out everything else, and they have the cardiometabolic risk factors. Patients might self-refer because they got an ultrasound that showed hepatic steatosis, and so they're coming in. And then third, we have targeted care pathways with the FIB4 algorithm. So once they come to me, it's all about fibrosis, right? I'm risk stratifying for fibrosis. We also use—
How do you do that? How do you do that?
We use FibroScan, like it's part of our physical exam. No one is leaving our office without, we have them right at point of care. So FibroScan is first. If I'm not happy with the FibroScan, I go to MRE.
Okay, do you use ELF test?
We haven't yet because payer reimbursement has been a little bit slower there, and it's very variable across the states. So I need to be very sure patient is not going to get a bill. And until I'm 100% confident of that, because I will lose that patient, they will be pissed at me, and I'm going to get a very bad patient review. So unless I'm 100%, and FibroScan is universally covered. MRE requires prior auth, so I'm not getting it unless it's going to be covered.
So do you, if you have a FibroScan, let's say of 12, do you do a confirmatory test, or you just take it for face value and say this is it?
If I know the patient and it's been consistent that that's where they live, I don't need anything else. And that's enough for me to, and oftentimes if they also have abnormal liver enzymes, there's all these other things that are going. So I don't need anything else if I have consistent FibroScan values in the range of, 10 to 15.
Okay, then a question. This is a yes/no question because we'll come back to it. Do you use PEth?
Yes.
In all patients with SLD or selected?
I would say 95% of them. I try not to be selective.
Okay.
I try to make it standard. Yep, I try to make it standard.
Okay, Mattias, I know you've used it for 20 years, so I will wait for you then. But I'll ask you another question, which is, do you use PNPLA3 in your clinical practice?
No, we don't.
It's a risk consistently associated with risk of steatotic liver disease.
I have in very few selected younger patients with steatosis without any other risk factors. And then just for my own curiosity, I've done genetic risk scores, maybe mostly to learn, really. but generally I don't use it.
Arun, do you use PEth? No, not you use PNPLA3?
PNPLA3, no. PEth, yes.
Okay. Okay, what do you use ELF test?
We do use ELF test, actually. We have not embraced MRE like some other centers because at least in Virginia, where we are, the reality is that the MRE generates a overall bill of a couple of few $1,000s.
Then you're like Europe. We also don't do it for that reason.
And even though it is easily available and you have to go through a pre-authorization process, we have not really embraced that in our care pathway. We do tend to use more ELF. There are some challenges.
Can you explain how you use ELF? When do you use ELF? You use that. You also, I guess, everybody use the VCTE and then or FibroScan, and then what situation do you use ELF? All the time or in selected cases?
No, it is selected because again, it is the reimbursement is a little not predictable. There are some payers that easily reimburse, others are not, and we're trying to figure out what's going on with all of that. But in the meantime, if the FIB4 and the FibroScan give us concordant data in terms of the overall sort of risk profile and the way we evaluate risk, and we've developed our own sort of risk visualizer, we look at the patient in a green zone, an orange zone, amber zone, and a red zone. Because the traffic light is easy to think about, explain to your colleagues, and also explain to your patients. And so if your FIB4 is below 1.3 and your liver stiffness is below 10, we're sort of in the green zone, because as we have seen from recent studies, the risk of a liver outcome in the next 5 years is very, very low when you meet that profile, regardless of what the fibrosis stage may be. And then there is the red zone where, it's 2.6 and your liver stiffness is over 20, or you have thrombocytopenia with a high liver stiffness, those kind of situations, and things in the middle fall in the amber zone. So we have been sort of thinking about it in the traffic light mode and focusing on the middle, the amber zone, as the to be treated zone. Because this is easy to explain to my nurse practitioners, because we have a number of nurse practitioners who are, in the US, we use a lot of physician extenders. And then this is very easy to implement this way. We have a standard, if the liver stiffness is between 10 and 20 without any thrombocytopenia, and your FIB4 is above 1.3, and it's only when you get discrepant results between FIB4 and FibroScan, then we'll use an ELF. Otherwise, we rely, if the two are concordant, then we don't get a third test.
Okay. So I tend to use actually ELF quite a lot. So that's, again, we're a little bit different here. How can we actually find it? Again, of course, I guess the saying is the last test is the one you can probably trust most. Again, all concordant tests are important. And I think also this depends on, for us, it's reimbursed, so we can use it. But it's also the question, I think, but that's a different discussion, that you are restricted in using a relatively inexpensive, non-invasive test, but you can qualify for a very expensive drug that can actually continue for a very long time. So that's, I guess, a system where this will be different unfolded in European public health systems, where you would do this health economic assessment and see how to actually find the patients in most need. But let me move forward here to discuss a little bit about alcohol, because I think we've learned, and Mattias, you started it there, that alcohol is probably underreported, and I think repeated results now from all over the world in roughly 30% of the cases that we think that don't drink alcohol probably belong in ALD or mid-ALD field. So how do we navigate that? Maybe, Mattias, you can say you've probably one of the centers in the world that has used PEth most for 20 years. How do you use it in Sweden, and how does that inform your clinical practice?
Yeah, we take it basically in all patients, and it is part of our workup to basically all referral patients that come to us. They have a PEth in the workup package. So we always have an initial PEth value when we see the patients. And then in most patients that we follow, we do take it yearly. But the most important thing for me is that PEth is just one variable. It has not a very long short life. So, I mean, it describes the alcohol for roughly 2 weeks. I think it's extremely important test, and we should implement it worldwide a lot. But we must use it with passion, and we need to know that this is not to tell our patients that they are lying. If we think that this is a test to detect liars, then we use it in the wrong way. This is one variable that you use together with the, how you ask.
Do you use audit C, Mattias? Do you use audit C or
only in studies? Only in studies. To me, to ask the patients, please tell me, how much do you drink? Describe, how do you drink? When do you drink? So if you do that in a very unconfrontational way, generally they tend to tell them. And then we also, they know that we take PEth. Then we also look at the PEth and we see, is this concordant? Sorry?
No, so do you inform the patients? I'm gonna take various
We
tests.
haven't done that, but currently there's a big debate in Sweden because our government has started to take away driver's license only based on PEth. So right now there's a very big discussion around PEth, and some of our patients don't want to come and see us because they are afraid that they will lose their driver's license. So to me, this is so sad. This is a disgrace that we cannot use one of the most important tests in clinical care, but hopefully we can sort this out. But I think this is something very important for all countries, that it's very important that you separate the government's need to validate driver's license and employment and all of these issues, and our need as physicians to have control on the most important confounder of our field.
So Meena, do you get consent from your patients before you order PEth, or you just do it a part of the package?
No, I mean, usually I say I'm doing a workup for your liver disease. I don't tell them I'm getting a celiac or HIV or Hep C. I don't explain every single test. What's a ceruloplasmin? I'm looking for, I do it like that so that there's no, because I say, I'm trying to figure out what's causing your liver disease. That's it. And it's not anything judgmental. That's the way I try to do it.
So what do you do then? Some patients have reported that they don't really drink, and then you have a PEth of, let's say, whatever, 150. What do you do then?
I mean, I think it's an opportunity for a conversation, because it could have been that they were on vacation for the 2 weeks before in Mexico, or what have you. So we do audit C as well, but it's more, do you struggle with alcohol? And you think about alcohol use disorder, and if they need medication to help decrease cravings, etc. So it just opens up the conversation.
Okay, so do you use audit C? I actually think audit C is very useful.
We do audit C, yeah, audit C.
Also in all patients with SLD or suspicion of SLD, I think that's also an important message, that it's actually easy. And it's been pushed by WHO since 1978 or something like that.
It's required by our MAs do it as part of their screening, and then you'll get in my chat message saying that the patient screened positive for alcohol.
So, Meena, just to pick on you a little bit more. So, not so many data, but at least we've done data with 1,000 patients. And again, if we follow them up and try to apply these criteria again 2 years down the road, it turns out actually whatever 30–40% move category. So how do we actually manage that? I can still not get my head around, because we love these beautiful categories, but do they truly exist if people move around? Should we rather see most of the patients as a dynamic risk? How do you tackle that?
Yeah, I mean, just like we talk about fibrosis, I don't need to know, are you exactly stage 2 or are you exactly stage 3? I know where you are in the spectrum, right? And I think it is dynamic, right? There's going to be different drivers at different times. Certain cardiometabolic risk factors are better controlled at this moment in time and then next month. So I think it is dynamic, and we shouldn't struggle so much with distinct categories, but more how patients
spectrum, yeah. So Mattias, he takes it, says once a year, but how do you use PEF? How frequent do you think it's meaningful, or do you individualize?
It should be individualized. That's the important thing, because you need, if you know the pattern of drinking with your patient, and that has been consistent and also in concordance with previous PEF, then maybe you don't need any additional PEF values. Once a year is how we do it, but I don't think there is something that fits all when it comes to frequency of PET testing.
So Arun, if you had a patient, or no, let's say we have a patient, one of your patients, he then comes in, you measure PET, it's 150, and for those who don't know the values, that's equivalent to what you would put them probably in ALD. They have significant alcohol consumption, not massive, but definitely not within the MASLD. And this patient has been, you put that on resmetirom and everything is good. What would you do? Because formally it doesn't meet the criteria, but it may work, you don't know.
Yeah, so, I think the classification system, if I may be, while, I participated in that whole process, but I'm going to push back a little bit on the
We're
classification.
only 4 people here, no worries.
Yeah, that the classification has been fantastic for generating interest and publications and, focus more research in this area. But from a very pragmatic perspective, it is such a dynamic process, as you mentioned. And so it comes back to being a doctor. You have to have that conversation with the patient that, listen, we ran this test. This is what it shows. And did you get exposed, or did you go on vacation? Did you have maybe a few drinks somewhere? We also, what I found one way to diffuse when the patient gets tense is also have this conversation that, there are some people who endogenously can make alcohol. We really don't understand that very well. We're really trying to understand what's happening with you. The other thing we found is that, so we're very fortunate in my clinic because I actually have a behavioral health counselor who's embedded in the liver clinic. And so for patients like that, especially if they say, yes, I did have some increase in alcohol or whatever, there was something that's definable, then we would have our BHC or the behavioral health counselor do an assessment. We view this whole alcohol issue more broadly than just part of steatotic liver disease, because patients with PSC also drink. People with PBC also drink. So for us, an assessment of alcohol consumption is part of a hepatology, history, and physical. And so audit C is done as standard of care by the intake personnel in the clinic and is in the chart on all the patients. And if you have a high score, or I encourage a lot of our junior faculty to ask the NIAAA recommended question: in the last 6 months, have you had more than 6 drinks on any one occasion? And if the answer is ever yes, then that's an automatic visit to the behavioral health counselor to get a more detailed assessment of alcohol use disorder, so that we can be proactive in intervening, and at least making people aware of the risks associated with risky drinking, and have a conversation about risky drinking. And we are increasingly integrating brief intervention right in our clinic, even with very early disease. I don't have to wait till somebody has alcoholic hepatitis to actually then start thinking about the underlying alcohol use disorder. We're beginning to start that whole process and assessment much earlier in the course.
I think that's a very important message, that the brief interventions, which is repeatedly shown to be able to reduce alcohol consumption, is something we all can learn. We actually had a workshop there on the hands-on sessions at EASL, training people in brief interventions. We don't have much time left, but I want to, again, a few things from you, Mattias. Let's say we look 5 years ahead from now. We are lucky that all these drugs come through and we have it almost like the endocrinologist. So if you look, what would your dream be for a system where you could really take good care of the patients? leaving as few behind as possible. Maybe basically see a way of a transformative shift like we've seen in Hep C. Could we imagine a similar shift in steatotic liver disease?
I mean, the one dream is that the primary care will be sufficient to really to take care of the big bulk of patients that have metabolic risk factors, obesity, and at least in Sweden, primary care is doing a great job with type 2 diabetes. I mean, the bulk of patients will get a good treatment even in primary care, at least in the Swedish system. And then my dream is that we will stop being so very nerdy in looking for absolute stage in fibrosis. And I really like Arun's traffic light analogy. I mean, generally, I hate to say this, but we need to be a bit more like cardiologists. I mean, they work with risk. And I mean, it's the risk to have decompensation, risk of dying in liver disease. That's the thing that we want to prevent. And I think we really need to have even better prognostic risk factors and then we treat risk. And hopefully in the future, we also reduce risk with all of these trials that are upcoming. And hopefully we also will have endpoint trials so that we are certain that we really reduce the risk with all of these treatments that are coming.
So going from diagnostic biomarkers to prognostic, I like that thinking. So Meena, from your perspective, without repeating what Mattias said, because I'm sure you agree, but let's say we are successful, and given what we already heard in the discussion, there's a good chance that these trials will make their clinical endpoints also. Let's say this is all good. So how do you see a scenario if we got a ton of drugs? How would your day look like, or what would your dream see? Well, how can we imagine a similar transformative shift if we're successful as was seen in Hep C?
Yeah, well, I think that the key will be all the responder analyses to understand which drug works best for which patient. I think that, I mean, none of these drugs have 100% efficacy, right? So the delta, the placebo effect. So I think really being much more personalized, which, you can say that about any disease, but I think that is the goal when you have so many different molecules that you can choose from.
Very good. So, Arun, your wisdom here. Can you help us looking in the crystal ball? I'm sure there's no investors out there. But will the MASH drugs we got these strong signals for, will they also work in patients with mid-ALD and ALD? And why? Or why not?
Well, I think for the Met-ALD, I suspect some of them will, based on their mechanism of action, both centrally and peripherally. Whether for ALD, when we're talking about, the severe alcohol-associated hepatitis patient being admitted to the hospital.
Oh, if we forget those and say those in steatotic liver disease spectrum.
Yeah, I think it will work for a substantial proportion of those patients. And we recently published a paper actually in the American Journal of Gastroenterology on a risk-based approach, because I believe with the new molecules that are coming, you can effectively defat the liver for even those with early stage disease. So if you're stage 0 to 2, when your principal risk is cardiometabolic, at that point, if you actually wipe out the fatty liver or steatotic liver, I would suspect very few of those patients, especially if their liver enzymes are persistently now normal, that very few patients will progress to more advanced disease, which is very similar to what happened with hepatitis C. When you treated the root cause, the proportion of people progressing to more advanced disease sort of really rapidly decreased. And of those with more significant disease in the middle zone, I think we will have effective liver-targeted pharmacotherapy on top of the systemic treatment for their competing risks to life. We have to get away from organ-based medicine to thinking about the patient, because the patient that the diabetologist and the cardiologist is interested in is also the patient that I'm interested in. We're all talking about the same patient. So we have to look at the competing risk profile, manage the competing risk profile, and use targeted therapies And as we mentioned earlier, it is looking promising even for people with advanced fibrosis.
Yeah, I very much agree. And of course, we don't know yet, but there are a few trials now also ongoing in ALD with some of these compounds. And let's see, I think it's interesting. At least there are some observational studies and also animal studies suggest that not just the peripheral or the cardiometabolic risk factor, but also the central effect in the brain would probably reduce alcohol consumption, both for FGF21s and incretin-based. We're coming to an end. Can you imagine? It always goes so fast. I would have loved to discuss and learn from you a lot more, but this is it. So I want to thank you very much for your time, and for all the people listening in. I want to invite you back next Wednesday, same place, same time, and we'll discuss the recently released EASL practice guideline on vascular liver disease. So you need to know what's new. Is there anything that will change how you should approach your patient? Then come and listen in next week at 6 p.m. European time.
Great. Thank you.